Hi, I'm Dr. Kim Langdon, and today we're going to be talking about chronic obstructive pulmonary disease. What it is, how it occurs, your risk factors, how we diagnose it, how we manage it and treat it. So let's get started. Basically, COPD is what is chronic obstructive pulmonary disease, and it's another term for emphysema and chronic bronchitis, as well as non-reversible asthma. It's very common. 15.3 million people have this. It's the leading or the third leading cause of disease-related death in the US, and it creates long-term disability. But with proper management, people with COPD can achieve good symptom control. We talked about the prevalence of COPD. It's more likely that women are to have this. Smoking is linked to up to 90% of all COPD deaths in the United States. Men are 26 times more likely to die from COPD than their non-smoking counterparts, and women are 22 times more likely to die from it than their non-smoking counterparts. So how does emphysema happen? Well, it's called damage to the alveoli, which are the little air sacs. The walls of these little air sacs disappear, and the little small sacs become one big, large single sac. And when they're larger, they do not absorb oxygen as well. And that means less oxygen is absorbed into the body, into the bloodstream and to the organs. So essentially the air gets trapped in these airways that become flabby and dysfunctional. And this creates shortness of breath. Bronchitis occurs when the bronchial tubes, which are the tubes that lead to the alveoli, become irritated and swollen. And if mucus comes up with a cough, and the cough lasts at least 3 months for 2 years in a row, the bronchitis becomes chronic bronchitis, and that is part of the COPD syndrome. Basically, there's hair fibers in the bronchioles, and these little tiny hairs are called cilia, and they help move mucus up the tubes so it can be coughed out. In chronic bronchitis, the tubes have lost their cilia. They don't work well. So it's very hard to cough up the mucus. And this just creates a vicious cycle of more coughing. Then the tubes become more swollen, more inflammation. All of this buildup leads to difficulty with bleeding or breathing and further damage. Then there's something called refractory or non-reversible asthma. And it's the type of asthma that doesn't respond to the usual asthma medications. And the bronchial airways tighten up and swell. Usually we have medications that can reverse this, but not in all cases. And this can lead to chronic lung damage, such as COPD. So there's, as you can see, we have the chronic bronchitis, which is 8.9 million people, and emphysema, 3.5 million get diagnosed with emphysema, also known as COPD. The risk factors for COPD is cigarette smoking, as basically long-term cigarette smoking. Other smokers, such as pipe smokers and marijuana smokers, might get this, and even people exposed to chronic secondhand smoke. People with asthma who smoke are also at increased risk for developing this. People who work in hazardous areas that have occupational dust and chemicals can develop COPD. If you are in a poorly ventilated place where cooking is done repetitively and not well ventilated, you can develop it. And it tends to develop over years and tends to develop after the age of 40. There is one genetic deficiency that can cause this, called alpha-1 antitrypsin deficiency. So what does COPD do? What are the complications that can occur? Well, respiratory infections are the most common. You're more likely to catch the flu, a cold, pneumonia, which makes it much harder for you to breathe, and it can lead to more damaged lung tissue. That's why annual flu vaccination is recommended. Because of the strain in the lungs, it also creates a strain in the heart, because if you're chronically not receiving enough oxygen, that strains the heart. And of course, COPD and smoking can lead to lung cancer. And we also know that COPD can lead to high blood pressure due to its effect on all the blood vessels and the heart. And over time, with difficulty breathing and this chronic disease, you can develop depression. So it's best that this gets under control so that we can avoid these complications. Sometimes you don't have significant lung damage, but you still may have some of the symptoms of COPD or chronic bronchitis. Some other symptoms besides cough and mucus production is shortness of breath, especially when you're doing something physical, wheezing or chest tightness, having to clear your throat first thing in the morning, or just having a chronic cough that may produce sputum or mucus. The mucus can be clear, white, yellow, pretty much any color. So a chronic cough can develop, which causes chronic mucus secretion, which can be clear, white, yellow. You can develop blueness in the lips or finger beds called cyanosis. You might get more infections as stated. You might have lack of energy, unintended weight loss. You might have swelling in the ankles, feet, or legs. And COPD can wax and wane. It can get worse at times and then get better. And it's quite variable in its course and duration and disease activity. So some of the morning symptoms across all COPD stages is that almost all people wake up with some sort of symptom. Commonly, it's a cough, sputum production, shortness of breath. If you do get morning symptoms, it's more likely that you've had to use oxygen in the past week. Your health status is not as good as it used to be. You've had frequent exacerbations, poor sleep quality, and higher anxiety and depression levels. So this is sort of a pictogram of different stages of COPD. In stage 1, you have 80% normal lung function. Stage 2, half of your lung function is bad. And then it just progresses to, 70% of your lungs are bad, and then even more than 70%, and you're in stage 4. Symptoms that you may be progressing is breathlessness, coughing more than usual, just breathing difficulties with just doing your normal everyday activities, coughing out more phlegm or sputum. If it's green, rust-colored, or contains blood, or you have weight loss and fevers, that's more serious and that would need to be told to your doctor. Also, dizziness and feelings of being lightheaded are serious as well. Emergency situations would include like some acute onset of chest pain, blue finger and lips, and severe dizziness and mood swings. The best test for COPD is called spirometry, and involves blowing out as hard as possible into a small machine, and that tests the lungs' capacity. It's a quick test. You get the results right away. Imaging test and the stethoscope, not so helpful. You might pick up something there, but a CT will usually diagnose COPD. And then if your oxygen status is in question, what's called an arterial blood gas can be done as well to see how much oxygen you're carrying and how much carbon dioxide. So it's called forced expiratory volume in 1 second, and that's measured over forced vital capacity. And so you do this test, and they do a ratio, and based on where you fall with that ratio determines kind of how severe your COPD is. And your doctors will diagnose your severity and make recommendations accordingly. So basically, an FEV value less than 80% of the forced vital capacity, or the FVC, indicates that you have COPD. This is another sort of diagram of, what your FEV might be in a very mild case of COPD. As you can see, the forced expiratory volume just continually goes down until you're in a very severe state. So pink puffers and blue bloaters. There's 2 different types of how we deal with the COPD. In the pink puffers, they try to compensate for their lower oxygen by what's called hyperventilating, breathing more frequently. So they try to maintain their oxygenation in their blood to the best that they can. But they do appear breathless because they're breathing more, but they don't appear to be cyanotic, which means they don't have enough oxygen. Then there's the blue bloaters, which they're not able to compensate as well. So they can't really increase their breathing rate or depth of breathing. So they tend to have a low oxygenation and a high carbon dioxide. And they might not appear breathless because they're not, overcompensating, but they do appear blue in the lips and fingers at times, and that can stress the heart. So what's the first thing to do? Well, the first thing to do is stop smoking, get regular physical activity, even if it's hard to do, but do that under the supervision of your physician. Eat a healthy diet, start a pulmonary rehabilitation program. Of course, avoid exposures to irritants and air pollution. That's why we have a smog index. It should be paid attention to when the smog index is high. If you need oxygen, you should use it, and stay well hydrated and practice relaxation exercises. So again, it's very, very important to stop smoking. We know it's very difficult to stop smoking because nicotine is addicting. One best way to stop is to just gradually decrease the number of cigarettes smoked each day. So if you're a 1 pack a day smoker, take out 1 cigarette each day, put it away, and only smoke the 19 left. And then gradually just reduce the number of cigarettes in that pack until you can get down to 0, hopefully, but the lower, the better. You can also do something like setting a date, hypnosis. There's nicotine withdrawal that does occur. Sometimes there's medicines for that. Even chewing gum that has a slight amount of nicotine can help suppress some of the symptoms that occur when you try to stop smoking, because you can get withdrawal from the nicotine. So other things that you can do to help with your oxygenation is do something called pursed lip breathing, which is breathing in from the nose only and then breathing out twice the amount through your kind of pursed lips. Diaphragmatic breathing means lying on your back with bent knees and then doing the pursed lip breathing, stretching exercises, and of course, aerobic exercises, anything that increases your lung capacity and circulation is going to help your breathing and make sure muscles around your lung rib cage strong so that when you do have exacerbations, you can tolerate them better. Of course, always warm up before you exercise, do something that you enjoy or find a partner. The ideal is to, shoot for 30 minutes of activity at least 3 to 5 times a week. Avoid hot and cold extremes of weather when you exercise, and avoid hot and cold showers after exercising. Avoid heavy lifting, push-ups, sit-ups, or walking up a hill. And talk to your doctor about the best way to start an exercise plan, especially if you're just new to the exercise world. And certainly you should stop exercising immediately if you experience nausea, dizziness, weakness, irregular or fast heartbeat, chest pain, severe shortness of breath, shoulder, jaw pain. In those cases, you should stop what you're doing, call your doctor or 911 immediately. Of course, diet and nutrition is important for all healthy lives, including those with COPD. You should try to shoot for a normal BMI of 21 to 25. And if you're under that, you should try to gain weight. If you're over that, of course, you should try to lose it. Water should be spread out throughout the day, an average of 8 glasses. Try to shoot for 4 to 6 meals, small meals throughout the day. That's helps your diaphragm move. And then any foods that cause gas or bloating are going to aggravate your breathing. So try to avoid those foods. So what are some of the treatments we might use to improve your breathing? Well, short-acting bronchodilators are the first line of treatment. And of course, your yearly flu vaccine. A longer-acting bronchodilator will be maybe needed, and pulmonary rehab if you have moderate COPD. And at times you may need inhaled corticosteroids in case of flares, if they get worse or more frequent. And in very severe cases, you might require, long-term oxygen therapy or lung surgery. So flare-ups are more likely during, the cold and flu season. So be careful during those times. Stay away from smoke and other pollutants, extreme weather changes, or feeling run down and stressed. If you start to feel more breathless than usual, try to be patient. Use your inhaler as instructed. If the inhaler isn't helping or coughing up more than usual, take your rescue pack medicine and call your doctor. And of course, if it keeps getting worse despite the medicine or there's a fever, call your doctor's office at once or 911. So bronchodilators do exactly kind of what they're named. They dilate the bronchioles so that you can get more air in and more air out, which means more oxygen in your blood. There's short-acting ones available, long-acting ones. They're different mechanisms, whether they're beta-adrenergic or they're anticholinergic. Doesn't matter. Your doctor will decide which one is best to start with you, depending on your needs and if you experience any side effects from other ones. Some of the common side effects of the beta-adrenergic bronchodilators are like migraine headaches or headaches of any kind, nausea, flu symptoms, ear infections, cough. It's hard to distinguish from the underlying condition itself. Other side effects might just be like an allergic reaction, which can happen with any medication: nervousness, tremor, wheezing, more shortness of breath. And some of the serious side effects might include that you have what's called bronchospasm, which is actually worsening of your condition, or anaphylaxis, which is a severe allergic reaction, low potassium, an abnormal heart rhythm or fast heart rate, elevated blood pressure, or chest pain. Those are all very serious. You should definitely contact your healthcare provider immediately. The anticholinergics commonly cause dry mouth, headache, nausea, dizziness. They might cause a rash or itching, indigestion, back pain. And if they're serious, you can have bronchospasms just like the others, and that can cause closure of the airways. Other side effects to other body organs include enlarged prostatic gland, and then also the worsening of narrow angle glaucoma. The xanthines, which were like the theophylline, those side effects include nausea, diarrhea, headaches, irritability, flushing. Other side effects include, excess urination, feeling restless, and poor sleeping, tremor. And in severe cases, you can go into shock, seizures, heart arrhythmias, low blood pressure, or a scaling dermatitis. So some of these drugs can interfere with other drugs you might be taking, for example, tricyclic antidepressants and monoamine oxidase inhibitors. There can be additive effects from those if you combine these. In any case, your doctor will guide you into the best course of action and will make all attempts to avoid these interactions. Beta blockers are others that can block the effect of some of the bronchodilators, so they can actually induce bronchospasm in people with asthma. Loop diuretics such as Lasix may increase the risk of low potassium, and another drug called atropine may increase the occurrence of other side effects. Here we have some common ones like Tagamet, which is an antacid, to stop reflux, and Cipro, which is an antibiotic. Some of the other antibiotics and antifungals can elevate theophylline blood levels. So again, this will be monitored very closely with your doctor and will likely be avoided if you're taking any of these medications. Herbs like St. John's wort, rifampin can decrease levels of theophylline, so you may need to have an adjustment upward or discontinue those altogether. And all drugs are excreted in the breast milk to some degree, so theophylline can cause irritability in a breastfed infant. You should discuss all therapies with your OBGYN if you are pregnant or breastfeeding. So inhaled steroids, their side effects include bruising, oral infections, and hoarseness, but they're often needed for people with exacerbations of COPD. Sometimes there's combination inhalers such as bronchodilators and the steroid combined. And then there's also oral steroids in addition to inhaled steroids, and that's for usually short courses for severe acute exacerbations of your symptoms. They can have some serious side effects if they're used more than on a short-term basis. Here's some more. This phosphodiesterase drug can interfere with other drugs associated with the use in COPD. Theophylline is one of the most common and inexpensive medications that help breathing. And then antibiotics are usually added if there's a suspected respiratory infection, such as acute bronchitis or pneumonia, because both of those can aggravate COPD symptoms. So what else could be prescribed besides medications? Well, oxygen therapy. There's a lot of portable oxygen therapy devices that have come a long way since in the last decade or so. Some people need it just while they're awake. Others need it also while they're sleeping. A pulmonary rehabilitation program is generally an educational program combined with exercise, training, nutrition, advice, and counseling. Sometimes hospitalizations are necessary in order to help people live a more normal life once they are discharged. So, all right, these are a list of drugs that can have possible adverse effects that actually cause shortness of breath or cough. I'm not going to read through them, but you can look at these later and make sure you're not on any of these. But there are a lot, some are, for cholesterol lowering, some are for rheumatoid arthritis, some are for cancer. So, and some are just antibiotics. So check that out and make sure you aren't taking any of these, and discuss that with your doctor. This is another list, quite extensive. Some of these are antidepressants, antibiotics, anti-seizure medicines, things like non-steroidals, which are over-the-counter. So there are over-the-counter interactions that can occur as well. So again, keep your doctor well aware of any additional medications that any other practitioner puts you on, or that you should inadvertently pick up as an over-the-counter remedy. More of a list. Some of these are just something like aspirin. Verapamil at the bottom is for high blood pressure. And then a lot of these are very common, some less common, but they can always interfere and cause adverse reactions and should be monitored. So some of the things they might ask you is, when you come in with an exacerbation of your COPD, is, has this ever happened before? Has it been as bad as it was before? What specific treatment worked in the past? Did the episode come on slowly or suddenly? Do you have any pain any other place? When's the last time you saw a doctor? If you changed your diet, added any new medications? What about your family, personal life? Are there any stress-related changes? Are you taking your medications on time? And maybe possible exposures to infectious diseases would be good to know. So as you can see, that's a comprehensive overview of COPD, the risk factors, how to diagnose, how to treat, things to look out for exacerbations. We hope you find this instructive, and please feel free to read the PowerPoint presentation in more detail, share the information with your doctor, and good luck. Thank you.